Welcome, everybody, to this webinar on overcoming complexity in TAVI, a patient-centered approach. I would like to invite you to join us for this webinar. Use the possibility to ask questions and to discuss this very important topic with us. Our today's topic will be discussed in a group of people. As you can see here, my name is Helge Möllmann from Dortmund in Germany, and we have Dr. Hahn with us from New York in the United States, and Dr. Kim from Gießen in Germany, and Dr. Lauten from Bad Berka in Germany. We try to discuss a couple of important questions, and you are invited to attend this PCR webinar if you want to discuss the different sources of complexity in TAVI, to learn how to adapt your procedural strategy to pre-procedural imaging findings, and to discuss optimal management of patient with heart failure undergoing TAVI. The TAVI market is steadily increasing. Everybody knows that we are more than 200,000 TAVI procedures per year, and the number of TAVI procedures exceeds the number of surgical aortic valve replacement by far. And this is most probably due to recent guidelines, the US guidelines 2 years ago, and here are the guidelines from the European Society of Cardiology. And as you can see here, TAVI procedures have been awarded somehow with a 1A recommendation, and every patient over 70 who is anatomically suitable should be treated with TAVR procedures. And what is this anatomical suitability of these patients? This is especially important in some special subsets, so patients with a small annulus, and perhaps patients with a low gradient aortic stenosis. And what we would like to do today is to discuss these issues together. And we have a talk at the beginning of our webinar concentrating on the imaging, the pre-imaging aspects, especially in patients with low gradient aortic stenosis. This talk will be given by Dr. Hahn. Then we have a case which concentrates exactly on that issue. And afterwards, we are going a little bit more to a patient with a small annulus and how to treat these patients. But let's start with the first issue. And Becky, I would like to invite you to give your talk on the low gradient aortic stenosis. Thank you very much.
Great, thank you. If I could have my slides up. So we're going to speak today about low gradient aortic stenosis, the different phenotypes and the management approaches, really the diagnostic approaches to these different phenotypes. And the first thing to understand is that there is a strong relationship between flow, gradients, and aortic valve area, such that there is a direct relationship between valve area and flow, as well as an inverse relationship between valve area and gradient, which means that in the setting of low flow, despite a valve area being severely reduced, the mean gradients could be very, very low. And as you have a higher flow rate for any given valve area, you'll see a higher mean gradient. And therefore, we have a situation where you could have low flow defined as a stroke volume index of less than or equal to 35 milliliters per meter squared, and a low gradient with a mean gradient of less than 40 millimeters of mercury, but a severely calcified as well as severe aortic stenosis defined by Doppler with a valve area of less than or equal to 1 centimeter squared, or a valve area index of less than 0.6 centimeters squared per meter squared. And so our guidelines now state that when you have a situation in which you have a low velocity or a low gradient in the setting of a calculated small valve area, then you have to exclude measurement error. And the first way to do that is to use the continuity equation. The continuity equation calculates the stroke volume as the numerator divided by the stroke distance, which is the denominator, and that's the velocity time integral of the continuous wave Doppler, and therefore normalizes for flow across the aortic valve and is valid in all situations. Now, one of the problems with the continuity equation is that there are 3 different measurements that need to be made. And one of the measurement errors is the failure to measure the peak gradient by echo. And we know that in those patients that have a large septal bulge and therefore an acute angle between the LV and the outflow, which is in figure B here, that we know that the peak velocities will frequently be directed toward the right parasternal region. And therefore, the right parasternal view becomes one of the most important views that you can get in, that you must acquire in those patients with particularly a septal bulge. Now, in those patients, the second error, most common error that we see is the LV outflow tract diameter. And the guidelines, unfortunately, have suggested that we should measure that the annular area or the LV outflow tract area using a single dimension, 0.5 to 1 centimeter below the annulus. But we know that that actually is going to underestimate the valve area. And indeed, what majority of us now use is the actual annular measurement. So don't go into the region where you have a septal bulge that will narrow down the LV outflow tract and artificially give you a smaller valve area, but instead use the annular area. And one other way that you can check on whether or not you have the correct annular area is to understand that the LV outflow tract diameter is almost linearly related to the body size. And so you can use these formulas, such as this predicted LV outflow tract diameter of 5.7 times the BSA plus 12.1 to check yourself and see whether or not you have the right LV outflow tract diameter. Now, the third measurement is going to be the LV outflow tract velocity time integral, which allows you to calculate the stroke volume and stroke volume index. And so we know that with a stroke volume index of less than or equal to 35 mils per meter squared, you have the situation of that low flow, low gradient. And so to measure the correct stroke volume index, you want to have the smooth velocity curve with a well-defined peak, which is figure B here, just before the flow acceleration that occurs in the setting of aortic stenosis. It's a little different if you don't have aortic stenosis. You want to be on the annulus, but for those patients with aortic stenosis, you want to be apical to the annulus when you're placing your sample volume. Now, if you have difficulty measuring the LV outflow tract diameter, we have one other parameter that we frequently use, and that's called the dimensionless index. Indeed, it's just the velocity time integral of the pulse wave at the LV outflow tract divided by the velocity time integral of the continuous wave across the aortic valve, and that dimensionless index criteria for severe is less than or equal to 0.25. And so now we have the ability to calculate the valve area, hopefully accurately. And in that setting, we have 2 different types of low flow, low gradient aortic stenosis that must be defined. And the first one is those patients with a normal ejection fraction. The second will be the patients that have a low ejection fraction. So in the setting of a normal ejection fraction, you have all these different possible issues that will characterize or explain the fact that you have paradoxical low flow in the setting of normal ejection fraction. Possibly the most common is going to be concentric hypertrophy with a very small ventricular cavity. But we also know that ventricular mechanics, even in the setting of normal ejection fraction, so low strain imaging, will also give you a low forward flow. Those patients with hypertension, what you see at the top there is an example of a patient that came to our cath lab and was given nipride in order to reduce their hypertension, and then yielded a very high gradient and high mean gradient with severe aortic stenosis. So hypertension, another reason for low flow, low gradient paradoxical aortic stenosis. And then, of course, in those patients with tachycardia, you know that the stroke volume goes down, even though the cardiac output stays the same. And that may be another situation for low flow, low gradient. Finally, we know that many of our patients are elderly and have concomitant disease processes, such as degenerative mitral stenosis or mitral regurgitation and tricuspid regurgitation, all of which can contribute to normal-looking ejection fraction on the left heart in the setting of low flow. Now, when you have low ejection fraction, this is where we like to try and increase the stroke volume to see whether or not it is a flow-related phenomenon that we have a low valve area, so that in the setting of a low flow, low gradient aortic stenosis with low ejection fraction, we perform a low dose dobutamine stress echo. The goal is to increase the stroke volume by 20%. If you have contractile reserve, you may then uncover true severe aortic stenosis with a high gradient and a low valve area. But in the setting of contractile reserve, and you continue to have a low gradient, but increase your valve area, you now have the situation of pseudo-severe or moderate aortic stenosis. And here's where you may have to make a heart team decision about intervention. If you don't have an increase in your stroke volume index, therefore you have no contractile reserve, then we can project the valve area using mathematical formulas, or look at the CT calcium score. And the most useful for us these days is using the CT calcium score. And using those scores and the cutoffs that I've shown you there, you can define true severe aortic stenosis or pseudo-severe moderate aortic stenosis. So again, calcium score becomes an important component of the diagnostic testing that should be done in those patients with low flow, low gradient aortic stenosis. The final step is that if you have patients with symptoms, then I think it's clear what needs to be done. And if you have those patients already with a significantly reduced LV ejection fraction below 50%, then I think, again, we know that those patients have a poor prognosis and need to go on to intervention. But in the setting of the absence of symptoms or a very low ejection fraction, then we have other markers of high risk. And they're shown here in the guidelines of high gradient aortic stenosis, severe calcification with a rapid progression rate, a very high BNP or NT-proBNP, left ventricular ejection fraction of less than 55% that is attributable to aortic stenosis, and then, of course, exercise testing with a sustained fall in blood pressure of greater than 20 millimeters of mercury. If you have one or more of these high-risk features, then it becomes a heart team decision as to whether or not you should intervene and how to intervene. Thanks for your attention.
Becky, thank you very much for this wonderful overview on this complex theme. It's always a little bit difficult to really identify the patients correctly. What I wondered is TOE in some sort still important, or is it only the transthoracic echo which you are using for these special subgroup of patients?
Yeah, that's a great question. We are using TOE as well. Remember, though, that even when we planimeter the orifice, that orifice, although it's small, may still respond to an increase in flow. So you have to make a decision at that point of whether or not you need to do the dobutamine stress echo or you rely on the calcium score. And more, we're trying not to expose our patients to any excess risk with the dobutamine stress echo and going to calcium scores. But we have indeed, in patients where we're not sure, the data is a little conflicting, we will go to transesophageal echo as well. And that will frequently give us a really full picture of the valve and the stenosis, including fibrotic regions. So sometimes the calcium scores may also be misleading. We've had cases where, particularly in females, but it can occur in males as well, where the calcium burden may be low, but the fibrotic changes in the leaflets are so obvious and so clear that we know that these patients really have true aortic stenosis.
I think that's a very important point. There is one question from the audience, namely, could you please clarify the paradoxical low flow, low gradient aortic stenosis and its management? short answer on this complex thing?
The slide that was very complex, we will use the calcium score again for those patients. And if they fulfill severe aortic stenosis, then it's very clear. But we also want to make sure we understand why they're low flow if their ejection fraction is normal, because it may mean that there are other things that we may need to treat. So if it's hypertension, it might mean that we need to treat hypertension. If it's a low strain, for instance, we know that there's up to 20-25% sometimes of patients that have amyloid. And those are patients that, again, would deserve further treatment. And then, of course, the ones that with concomitant valve disease need to be followed very closely after their intervention so that we don't miss the opportunity to treat those patients that have persistent mitral regurgitation or tricuspid regurgitation.
Maybe there's time for one question to Becky. Thank you very much for this excellent presentation. You are talking about the butamin stress echo, which is validated for low flow, low gradient, so with reduced ejection fraction. What about paradoxical low flow? You recommend doing it? Can we give it a try? What is your opinion on that?
Yeah, so in the guidelines, it says, at least the US guidelines, that you can attempt dobutamine in the setting of normal ejection fraction. But my personal caveat to you is that those patients with very hyperdynamic LV function may then have a Bezold-Jarisch response, which will then possibly kill the patient because their blood pressures will drop and then you won't be able to recover them. I am very reluctant typically to do it in the setting of hyperdynamic LV function. And so it's just a caution. It says you can use dobutamine. I usually try to avoid it and go to calcium score.
Perfect. So, Won, you treated a patient which is at least similar to what we just discussed. Perhaps you're so nice to share your case, and then we can discuss this case in more detail.
Thank you very much, Helge. Following Becky's excellent presentation, I'm happy to share the case. Can you see? Yeah. So it's a case that really fits to the topic that we have, and I think it's a scenario that we frequently see in our daily clinical practice. And so let's go straight forward to the case. 83-year-old male patient, BSA of 1.74. This patient is highly symptomatic with NYHA class 3 and also prior decompensated heart failure. And this is underlined, confirmed by elevated biomarkers. And I intentionally added the hemoglobin because anemia could also be a competing cause for shortness of breath. Looking at the comorbidities on the right-hand side, a patient had prior CABG back in more than 20 years ago, but also this patient has chronic pulmonary disease. So it's a rather severe stage with chronic oxygen therapy. Also, this patient has AFib and also hypertension. So I think it's important not to only to look at the comorbidities in terms of risk classification, but also to look at competing causes of shortness of breath, especially in relation to the topic that we have. Because what we have to find out now, and you can see in the following slide, the echocardiography, PTE, and you may appreciate that the ejection fraction is more or less preserved. We have a mean gradient in between 19 and 22 millimeters of mercury. The LVOT diameter, we can discuss that, was measured with 20 millimeter, and this resulted in a calculated aortic valve area of 0.9 square centimeters. The problem that we have here, and you can see it here in the slide on the right-hand side, that the stroke volume index is 43. millimeter per square meters. So the question that we have here is, we do have preserved ejection fraction, we have low gradient, but we have not a reduced flow. So this patient formally does not meet the criteria for low flow, low gradient aortic stenosis. So what to do? We did coronary angiography routinely, and you can see that female bypass is patent. The right coronary had a lesion here that we also treated right away, as you can see here. And of course, in this situation, we required an additional imaging. We talked about TE. This is what we have done. You can see the opening area here on the left-hand side. And you can see also the difficulty in TE beyond what Becky mentioned. Even the measurement on TE, the planimetry, can be challenging. There are two different measurements. One is roughly 1 square centimeter, one is in a moderate area, and you can also see what it looks like on 4D. So of course we did a computer tomography to measure the annulus, the LVOT diameter. You can see the coronary distance, and most importantly, we looked at the Agatston score, which was higher than 2,000 Agatston units. And this would classify the patient, or at least indicate that the aortic stenosis most likely is severe. I have an interesting slides, because what we measure on TTE in the long axis usually corresponds to the short axis on CT. And you recall that we measured an LVOT of 20 millimeters and with an adjusted measurement. And the minimum diameter would be in the range of 18 to 90 millimeter. At least stroke volume index would approach low stroke volume. So the question is, and this is what we discussed in the heart team, we want to make sure that when we treat the patient in this low flow situation, we want to make sure that the patient really benefits. And you have seen that there are a lot of competing causes that could make shortness of breath. We have severe paradoxical low gradient. The patient is highly symptomatic. We have to acknowledge that. And severity was indeed confirmed by calcium score and TE. And the heart team decision, and we can discuss that, how you would do it in the panel, was to proceed with TAVR. Transfemoral approach was possible, and predilatation, implantation of a navitor vision. Thank you.
Perfect one. Thank you very much. This is indeed a very challenging case with a lot of parameters which could contribute to the clinical situation. First of all, I would like to invite the audience to ask questions using the Slido tool, or to discuss on whether the heart team discussion of Won's heart team was correct or not. Let us have a look in the panel. Philipp, what do you think? Are you confident that the diagnosis by Won is correct?
Yes, I am confident, but I have one question to Won. When do you, if the diagnosis is really correct, we will see it afterwards. When do you perform the TAVI? Do you wait some weeks after PCI and make another?
Yeah. That's a very good question. Doing PCI before or after? I don't recall. I think I was not involved directly in the planning, so my personal preference is doing PCI afterwards, because there's signals that under that there's more bleeding. So, but of course, this depends on the anatomy, on the coronary distance, on the valve that you choose, on the expected coronary axis. So there are a lot of factors. We are, of course, waiting for TAVI PCI, the randomization showing us hopefully whether PCI before or after TAVI is better, but I think this will remain, even with the data that's expected, a very individual decision. So in this case, of course, yeah. And I know what you're alluding to. PCI and the stenosis could also theoretically be a cause of shortness of breath.
Yes, and especially in this case of paradoxical low gradient, if you remove the ischemic problem of the myocardium, and the idea to increase the stroke volume after PCI, that's my question focuses on: is it an option to make a PCI first in this special entity of aortic stenosis and wait 6 weeks and make a clinical assessment, maybe in another treadmill or something like this, and to prove the severity of the stenosis afterwards? You know what I mean?
Yeah, absolutely. I think it really depends on the lesion. And if you have a proximal LAD lesion or a left main, you could probably expect some improvement. But whether this translates into higher gradient or a different measurement, I'm not sure. I think at the moment of the diagnosis, you should have modalities to really make sure to make a decision whether you think this is severe or not.
Becky, how would you?
Yeah, I think the CT scan, the CT Agatston score really kind of, answers the question for all of us, with it being 2200. So clearly above the cutoff that we know is prognostically significant for males. But in addition, there are studies, and it's not made it to guidelines yet, that suggest that low flow, low gradient in males should be defined differently than in females. And the cutoff there is going to be 40 milliliters per meter squared, which you would have made if depending on exactly where you made that measurement of the alveolar flow tract. So I think for both those reasons, but primarily the CT calcium score, which for us will frequently decide the case pretty clearly, the decision was right, and those are patients that even if you improve the stroke volume, you still have severe aortic stenosis.
And the ejection fraction was still okay, so the probability that we further increase the stroke volume is perhaps not so high. This additionally confirms more or less the diagnosis. Won, perhaps you would like to share on how you did it?
Yeah. Of course, there's still some questions on the slide. Or should we answer them first, or what do you think?
I didn't get them so far. Oh, no, yeah. First
So,
question,
Dr.
high blood pressure in this patient was well controlled?
I can answer it briefly. So blood pressure was not a problem. Hypertension was only a risk factor. So it's number one. And Becky explained that we need to control the high blood pressure before we assess severity. And can you explain the reasons for choosing Navitor? One reason is that in this patient, obviously, you need to have coronary access. And I think Navitor is a platform that allows improved coronary access. We have a relative small anatomy. So the question is whether to use a balloon expandable platform that will result in higher gradients. And so the choice I made was Navitor, because you have really good gradients despite of being intra-annular platform, and you have probably really good coronary access. So these are the main reasons. And I could proceed with the implantation. Yeah. And you have seen the discussion, and I think, the conclusion was that it is really acceptable, okay, to proceed with the procedure, not to remain conservative. And this is what we did. Pre-dilatation with a 22 millimeter balloon. You will see the final result showing no relevant aortic regurgitation. Gradient was good. We had to do a post-dilatation, which rather speaks for severe aortic stenosis, right? And So this is the outcome that we have with the patient. Yeah, thank you.
Perfect one. This seems to be really a perfect outcome. Do you still remember the gradients afterwards? Because there was this discussion on why to use Navitor, and the hemodynamic situation, of course, is a point which we have to discuss. Do you remember on the gradients after the procedure?
I think it was 1-digit gradient. Yeah. I should have provided them, but it was 1-digit. Usually with Navitor, you have gradients, mean gradients in the order below 10 millimeters of mercury. So it's really good.
Perhaps you can just shortly highlight why it's so important in these patients, not only because of their rather small anatomy, but also perhaps the other factors that would speak towards a good hemodynamic valve.
Yeah, that's a very good point. So we frequently struggle in a daily clinical practice which valve to choose, and I think it really has become an art to choose the best of the different platforms that are available. And in this situation, an intraannular design. So leaflets are intraannular, but still due to the leaflet configuration, we have a very good opening, so hemodynamics is still good. And due to the intraannular design we have, and due to the large stent struts that we have a relatively easy coronary access, but also in terms of redo TAVI, I think it is a little bit easier to do redo TAVI having an intraannular valve design.
Becky and
Another
Philipp.
question?
Yeah, go ahead.
Kim, if you maybe there's a degeneration of the prosthesis, and which kind of valve you were thinking for revalving?
In this case,
Yes.
yeah, I would choose a Sapien, probably a balloon expandable platform.
Because of the coronary uptake or the sinus, or what do you think?
Yeah, I mean, if you choose another self-expanding long stem frame valve, you have the problem that you might not be aligned exactly with the previous prosthesis, and then you have you might have difficulties to get coronary access.
Yeah,
it is possible, but it's yeah.
There's one question from the audience, which is really interesting. I would like to ask all three of you, do you think that soon artificial intelligence will be able to choose the right valve concerning type, size, based on the patient's data, and even in these complicated scenarios, or is it still our own brain work which is important in these cases? Perhaps I start with Becky. What do you think? Will this? Of course, it's difficult to answer, but what's your guess?
Yeah, I think there's actually, I thought that there might have been actually a recent publication on that, on the use of AI. I think that obviously a lot of it has to do with the data that's being used to generate the AI algorithm. And so that's going to be, I think, the difficulty for most of us in accepting just using an AI algorithm alone without using our own brains. Because again, you know, garbage in, garbage out type of thing where you're dependent upon data that's perhaps not completely, you know, open data. So I do think that we can use algorithms to perhaps get us closer. We need to know not just about, you know, specific characteristics of the valve itself, but also the angle of the aortic root, and then of course vascular access and the need for coronary access or concomitant diseases. And so it's becomes a very complex algorithm, but I think AI might get us close to deciding between two platforms, let's say, and then from there, it's really using our experience and also what the site is the most you know, used to using. Experience there plays a large role in the appropriate implantation of these devices.
I think this is a very important point that you just made. So it's not only the proper valve to choose, it's also how to implant the valve. And if you're more experienced with the one product, perhaps AI will mislead you to the other ones. And therefore, this is a very important point that always has to be in mind. Okay, I think we have to continue a little bit because we are not only concentrating on these patients with a low gradient aortic stenosis, but also on patients with a small anatomy, because this is also difficult often to diagnose on the one hand and to treat probably on the other hand. And Philipp has prepared a case which he would like to share with us, and then we can discuss this special topic as well. Philipp.
Thank you. Yes, that's it. Okay, having patients with small anatomy, this is really, really important, even in the population and the indication of TAVI and younger patients. I think on small women with a small anatomy, very often in former times with the sophisticated planning for TAVI and maybe bad hemodynamic results or worse complications like anus rupture. So I think it's really important to have a look on the CT. I will show it in my talk and my presentation, and even on the case. Okay, no conflicts. This is also a female patient, very active lady, 85 years old, small person with a typical symptomatic for an aortic stenosis, for a high flow, high gradient stenosis. Dyspnea nearly on rest, but also on treadmill, ST segment, depressions, anterior plus angina, maybe a combined problem with a coronary calcification and aortic stenosis, even highly elevated proBNP, and a known coronary artery disease, a three-vessel disease with some stent episodes in former times. It's hypertension, diabetes mellitus, and bronchial asthma. So echocardiography, as I mentioned, high flow, high gradient, nearly clear 62 to 41 millimeter mercury, normal ejection fraction, opening area 0.8, and stroke volume was fine. So it was a classical high gradient aortic stenosis. So in our hospital, I think in many others also, we perform at first the CT scan. In the CT scan, and also to a known coronary artery disease, we saw the stents which were implanted in a former history, and also a high and maybe relevant stenosis in the LAD. So we performed coronary angiography plus PCI. Yes, you can see on the right side, and performed in the same setting of the hospital admission, the planning for the TAVI in our heart team. So you can see here the vascular access and the aortic arch, and also the calcification on the valve. I will go in detail now. So we start in our screening for TAVI with our heart valve nurses in the LVOT. In the LVOT area, you see a really small anatomy with 18.2 millimeters. This very small perimeter which you use for the valve sizing and valve choosing. And also, if you go on the middle frame, we see a small annulus with 20 millimeter in the tricuspid valve, also a little bit on the cut on the coronary artery disease. And the next situation, not in this case, but if you perform CT screening and CT evaluation in a heart team or in the pre-setting of a heart team, and have tricuspid anatomy and a lot of fibrosis, not a lot of a lot of calcification. Sometimes it is really important to have a look if you do an intermediate sizing of the valvular independence of the aorta and mitral orifice, and the coupling between systole and diastole is sometimes really impressive in sizing, and we use the diastole sizing not often, but if there are an intermediate sizing between two valve sizes, then it's really important to see both cycle parts and see both parts for sizing and for the decision which valve, maybe another valve than in the first thinking, but maybe also a bigger valve if you use supraannular valving. It's really important in the CT to screen, that the aortic root shapes. We have tapered and flared root shapes according to the LVOT. This is important, especially if you use self-expanding valves, because the risk of embolization, maybe if you implant the valve too deep, and they tapered in the middle frame, and the taper anatomy, which open the LVOT, and the valve is maybe embolizing in the left ventricle. So it's important to have a look on the root shapes in the CT screening, even for the impression from the sinus. And if you have a heavy calcification in the LVOT, is also important to have a look on the root shape, because in my experience of the way how deep or how high you implant the valve, even to reach a perfect result according to paravalvular leakage. The complex relationships are well known in the aortic root according to the conduction system. We measure in our CT screening routinely the height of the membranous septum. It's very often important to avoid conduction disturbances like a high gradient AV block. It's not in 100% of the cases, though, but if you have a very long membranous septum in CT screening and you have it in 3D reconstruction, you can play with the valve, even if you have on the other side maybe an LVOT calcification, put it deeper to avoid PVL, but also to avoid high gradient AV blocks or conduction disturbances, which leads to pacing or pacemaker implantation. So this is important for the screening, especially in small anatomy, because the place for the implantation of the valve is really narrow. So this is, I think, a nice idea if you implant TAVI prosthesis, to have a look as first operator or second operator, even as heart team, for the whole anatomy you have to deal with. So you start in the LVOT and go up in the double oblique view to see the annulus, to see the width of the sinus, the uptake of the coronary arteries, the distribution of the calcification. And you do it also in the idea of for the best result, for the height of the implants, of the valve, for the landing zone, for the coronary access later on, as Won-Keun mentioned, for the idea of the distribution or the movement of the calcification when you implant the valve, for the idea for the pre-dill, which size of the balloon you use for pre-dill. This is really an important question. It depends also on the calcification amount and or the idea to not to pre-dill, just making first implantation, even with self-expandable valve. The cusp overlap technique is also well known, I think, for the height of implantation, since 2017, 2018, we use this technique to implant the valve high to avoid conduction disturbances. I think it's on the CT data set routinely used and really important. And so we can reduce, it was for us possible to reduce our pacemaker implantation rates to a single digit amount. So the next step is vascular access. We know in patients with a small anatomy, there very often small femoral arteries. We scan the clavicles to below the femoral head, even for the idea for alternative access. If transfemoral approach, like you see on the right hand of the slide, is not possible. And this is even in the data set for the heart team evaluation mandatory to use the view on the vascular access, even for the success of the valve implantation afterwards. As I mentioned, transaxillary scan is for alternative access in our routinely setting. This is the main alternative access in our heart center, I think in most heart centers worldwide also. So you can use it in your data set to have an answer if transfemoral TAVI is not possible. So for our heart team discussion, in our case, there are some specific issues and key challenges. The small aortic annulus has a higher risk for patient-prosthesis mismatch and elevated post-procedural gradients. I mean, the hemodynamic with maybe a balloon expandable valve is probably not so good. Like in supraannular prosthesis, we have low coronary heights and narrow sinuses. So the increased risk of coronary obstruction is maybe a problem, and it has to be discussed in the heart team. And small peripheral vessels, not in our case, I presented, but maybe access complications are also a big problem if you use expandable valves, if you use expandable sheaths and balloon expandable valves, if you need a bigger vessel without calcification, and sometimes the low profile prosthesis and supraannular setting in self-expandable setting is much more better. So the idea in this case, in this special case, is to use a supraannular self-expanding valve, expandable valve to optimize the orifice area. We did a careful balloon sizing and I show it in the case, an 18 millimeter balloon. And if you need, in our case, was not needed coronary protection strategies, you can use a guide wire or an undeployed stent for parking in the coronary artery, maybe for chimney technique or in selected cases, maybe basilica, like the idea for leaflet modification, just to avoid obstruction and to give the possibility to recannulate the coronary arteries. Just a short glimpse on the data for small anatomy is a smart randomized clinical trial. The SMART trial showed that self-expanding supraannular valves are clinically non-inferior to balloon expandable valves in patients with small aortic annuli. Supraannular valves demonstrated significantly better hemodynamic performance with lower gradients, a larger effective orifice area, less valve dysfunction, and markedly reduced prosthesis patient mismatch. Overall, self-expandable valves provide better valve durability markers and improved quality of life compared with balloon expandable valves in patients with small anatomy below 23 millimeter. This is really important, and this is also what we what we see in our clinical practice, better hemodynamics and better clinical outcomes in patients with small anatomy and supraannular valves. So in our heart discussion, we use the idea, we had the idea of an supraannular valve, and we implanted, according to the sizing chart, the 23 millimeter Navitor valve with a good intraannular option and the idea for best hemodynamics, and did a pre-dilatation with an 80 millimeter balloon, did wire pacing, and let me show you the last slide, the implantation process. You do it very slowly. You develop the valve very slowly with resheathing the capsule of on the guide sheath. You see the marker spots. There are 3 marker spots. You see one on the nose cone, but not on the nose cone, on the valve bearing device. You do it very slowly. We do it not in fast pacing, just in normal algorithm. Then the valve is implanted in the middle of the slides, and we did a post dilatation with a really nice result, even on the idea of paravalvular leakage without any problem and no conduction disturbances in the end. Thank you.
Perfect, Philipp. Thank you very much. This was a really good result for a patient with an demanding anatomy. So annulus being so small is always a tough decision on how to treat. One, do you agree on this procedure? What would you have done perhaps differently?
I think the selection was very good. I mean, what we basically have to discuss is we want to avoid prosthesis mismatch. We know that supraannular devices result in better hemodynamics, less ppm, higher device success, etc. So what we do not know, and this is a matter of debate, is whether ppm or increased gradients that we see translates into long-term outcomes. So this is not really clear. Would like to hear what Becky mentions on that. So I think it's important to nevertheless to try to achieve the best possible outcomes, so to have highest procedural safety. And if this is given with 2 different platforms, of course, I would opt for the platform that yields better hemodynamic outcomes. And with the Navitor, as I said before, I think even though it is not supraannular, it is a definition intraannular, but of course the leaflets are a little bit higher. You achieve really good hemodynamic outcomes. I'm not sure, Philipp, whether you mentioned the gradients after the procedure, but usually also in very small anatomies, gradients are not so bad. I would still expect you did post-dilatation, relative low gradients.
Single digit, as in your case. I didn't mention, but it was single digit and really good, And balloon expandable prosthesis, I think we expected really higher medium gradients.
Especially given this very, very small anatomy, I think the single-digit result is very, very good. I have one question from the audience, and then I would come to Becky shortly. But first the one question before. The post-dilatation, how was this done? Because this is a really small anatomy. Did you use the 18 millimeter balloon again, or did you use a larger one? So if I remember correctly, the annulus was measured with 20 point something. What was your post-dilatation balloon?
We post-dilated 1-to-1 with the 20 millimeter balloon. To expand the valve, we have the annulus was not really eccentric. But the idea is from the post-dilatation to fit the valve in the anatomy. In a balloon expandable valve, you modify the annulus. In a self-expandable valve, you have to modify the valve for the annulus. You know what I mean?
Yeah.
So the post-dilatation is really important for the best hemodynamics and at one and on the other hand also to avoid a PVL. So you have to make it. I don't like the word aggressive in the setting of TAVI, but you have to do it really often one-to-one.
I think that's a very important point to try to get the perfect result, both hemodynamic wise and PVL wise. So not to accept the one or the other. What we still have to discuss, and I would like to ask Becky on this. So we are always talking about the gradient, and we try to bring the gradient down, use dedicated devices with a potentially good hemodynamic situation. However, there is quite some discussion about the difference between invasively measured gradients and echo measured gradients, and what one already mentioned, the meaning on the long-term outcome. Perhaps you can allude a little bit on this topic.
Really interesting topic because we've actually studied this on the bench as well, and it turns out the two different platforms, balloon expandable versus the self-expanding, not the Navitor, but the Evolut valve we've looked at on the bench, and it turns out, and as well as invasively recently, and the echo gradients across the balloon expandable routinely are higher, but the invasive gradients are actually lower, and that's because there's a little more pressure recovery in the short frame valve, and there's a little bit more of pre-valve acceleration, which doesn't obviously play any role in really the valve area, but it gives us a bigger gradient, and our calculated valve area then becomes smaller. So it turns out that the two platforms are very, very different, and that we've not been able to show any, at least in any of the partner trials, any outcomes related to prosthesis patient mismatch. And so it's important to realize that because they're so different, that the gradients are a little bit artificial, but I mean, they're both real. The echo gradients are really what we measure, and the invasive gradients are real as well. But with the invasive gradients, Amar Abbas has shown that the balloon expandable valve actually has a lower, in the small annulus patients, has a lower gradient, lower invasive gradient. So we want to be a little bit cautious about that, but I'm not going to say that gradients are meaningless, right? Although we have no outcomes, hard outcomes, so mortality outcomes associated with high gradients, we don't really know yet what happens to the valves as far as hemodynamic valve deterioration, and whether or not structurally those valves are now feeling the high gradient with the extra fluttering and stress on the leaflets, and whether or not that may, in the long run, play a role in structural valve dysfunction. And so I think that remains to be determined because we're still, trying to gather 10-year data and 20-year data on these valves. Again, so far, we don't have a great signal at all. The Swiss TAVI registry came out, showed that gradient has nothing to do with outcomes, that really what plays a role in outcomes is the baseline calcium, because remember, we don't take the leaflets out. They're still in there, and they're still calcifying, which may be why you can generate new PVL or worsen PVL over time, because the leaflets are still in there and they're still biologically active. And so the Swiss TAVI registry showed that it's the base, and other studies as well, that it's the baseline calcium that will determine in the end outcomes. And then they also showed something really interesting, which is that if you use Coumadin, which ends up being, promoting calcium, believe it or not, then you may actually have worse outcomes as well. So, and those are patients with atrial fibrillation that are on Coumadin, et cetera. So I think that there's so many things we don't know yet about valve durability, and we don't have great signals that gradient or prosthesis patient mismatch right now play a role in either valve durability or long-term hard outcomes. But I think we still need to gather the data, and I'm not going to Susanne, I do believe that in the end, we even at our institution believe that we should use a valve that we think is going to give us the best hemodynamic result.
I see there is a good reason to meet again in 5 years here in order to have some more long-term data, especially on this very important topic in the small anatomy. What we discussed today is that even patients with these difficult anatomies can be treated safely. You have to do a very careful diagnostic workup. You have to use the imaging as good as possible, and this holds true for both low gradient aortic stenosis and patients with small anatomies. And we tried to show you how to tackle these two subsets of patients, two difficult subsets of patients. I would like to thank all speakers, all panelists here for this very nice webinar. I would like to thank the audience for really important questions, and I wish you a nice evening. Bye-bye.